what we're going to do is I have about 20 to 25 slides, about 20 to 25 minutes of content that I'd just like to describe related to what we're seeing with hepatitis A in Philadelphia, the declaration of the public health emergency that we issued on August 1st, talk about some of the response activities that have been occurring, but then to really call on many of you in the healthcare sector to help us ramp up vaccination, because that's absolutely what's going to be needed to stop this outbreak from getting worse. And so with that, I'm just going to start with presenting the slide deck. And so we did declare a public health emergency around hepatitis A on August 1st, but this has been a problem that's been brewing for a number of months for us, and I'll show some epi data that will describe how we got started pretty much late last year and then early into the winter months of this year, but then it's really escalated into a massive outbreak starting in May. So the next slide just shows that this problem has been happening now for about 2.5, 3 years in other parts of our country, and now it's here. So massive outbreaks occurred in California to begin with in early 2017, particularly the cities of San Diego and Los Angeles to a lesser degree, but really San Diego and then some of the Bay Area, Santa Clara County had big outbreaks. That state, California, is really now declared over. They're on the other side of this big outbreak, and I'll describe a little bit of the activities and what we learned from San Diego that we think have to happen here in order for us to curb this outbreak. But the hotspots right now and over the last year have been in the Ohio Valley, really states like Kentucky, Tennessee, Ohio, Michigan, and West Virginia have had really high numbers of cases. And so we have seen spillover from big outbreaks in those areas into Western Pennsylvania late last year, but now the big city with the hot problem right now is us. The one thing to note about these increases in hepatitis A, we've always had small amounts, 2 to 6 reports a year of Hep A cases each year in Philly, and primarily that was international travel or men who have sex with men. But the outbreaks we're seeing since 2017 around the country have been in this drug-using population or people who are homeless or both. That is predominantly who now is driving these outbreaks. Okay, so this slide shows the Philadelphia data, and from going all the way back from 2001, you see that once routine vaccination of hepatitis A was initiated in the US in 2006, numbers really dramatically decreased, and we don't see cases among our pediatric populations. So like I say, from 2011, 12, to recently, we had about 6 cases a year. And then in 2017, we started to see an increase primarily in men who have sex with men and international travel. And the same was true in 2018 when big outbreaks were happening in Michigan and in Kentucky. We didn't see that homeless and drug-using population drive our numbers then. But now in 2019, with a lot of the year to go, we have 176, now it's 190 confirmed cases. And we have many under investigation, and so this is really just blown up into a massive outbreak. The next slide shows Philadelphia data of hepatitis A confirmed cases with the risk factors that we know about when we interview the cases. And so the yellow and the orange bars are either drug use or drug use and homeless. And then the green is unknown, meaning they're not telling us that they use drugs, or they're not disclosing that they're homeless, or they're not telling us that they're a man who has sex with men, or other risk factors are being learned. So clearly, we haven't seen really any of these cases in drug using or homeless until April of 2019, where we had 2, and now we have most of the new cases. And I don't want to, August 19, there's only 2 cases on this chart. There are many under investigation, and many more have been confirmed. So you can see that the number of cases by month are dramatically increasing. We had 80 confirmed cases in July, and that number will continue to increase. All right, the next slide shows just some of the numbers and percentages of the breakdowns of some of the risk groups. And so 39% of the 2019 cases, so just the current outbreak we're looking at, 39% report drug use, 26% report drug use and homeless, and then we have this 25% that is unknown, that we suspect may be using drugs, may be homeless, may have some risk factor, they're just not disclosing it. But what I will say is we have had cases that we will never know the risk factor, and it might be no to all the questions that we ask. And in those cases, it's either potentially being transmitted through eating food from a restaurant that was contaminated, or having heterosexual contact with somebody, and other things that we don't typically ask about, that are ways that people are getting the disease. So this is definitely affecting other people besides people who use drugs and are homeless. Okay, so the next slide shows where the cases are primarily occurring. And so most of the cases are centered in the zip code of Kensington, that part of the city. But we do have cases reported from all over the city. The other thing I'd say about this outbreak is we know this is going to get worse for a substantial number of weeks and even months ahead. So we're in this for a while before we're going to see a big decrease in the number of cases and can declare this outbreak is over. All right, so the next slide shows a table where we have some of the data broken down on the 2019 cases compared to last year's 17 cases. And what I'd say about this curve is a lot of hospitalizations. And so 74% or 130 people of the 172 have been hospitalized this year. So the strain of hepatitis A we're seeing with these national outbreaks is severe, and it's causing a lot of hospitalizations. We have had one known death associated with the hepatitis A infection, and we have recently learned about some severe complications resulting in liver transplantation in other patients that are occurring. So the worry that we have with this disease is that it is severe, and it is causing extensive hospitalization, so high cost to healthcare, and also potentially liver transplantation and deaths. We expect more of that will occur. Okay, the next slide is our emergency department syndromic surveillance we do in Philadelphia. So this is all the EDs in Philly. We get a de-identified data set, and we look at the chief complaint. And when we write, we look for words like hepatitis or jaundice. This is what we track. And so this is not specific. This could be due to other things other than hepatitis, and certainly other types of hepatitis, not just viral hepatitis, and other viral hepatitis, not just hepatitis A. But it's a good measure, and the new graph that was produced yesterday, it has a marked increase here that's even more extreme than what I'm showing in this graph that was completed at the end of July. So EDs are definitely seeing increases in patients presenting with jaundice or hepatitis-like clinical presentations. Okay, so that's basically the background on the cases we're seeing in Philadelphia and what we know about them. What I wanted to do is just step back and just talk a little bit more about the virus itself and important elements about how it's transmitted and what are its characteristics. So it's an RNA virus. It does survive in the environment. It contaminates food and water and then concentrates in shellfish. And those are typically the things we have seen over the years of the sporadic cases we've gotten in Philadelphia are typically related to this kind of exposure. Fecal, oral, or parental transmission are the modes of transmission here. So this is not like hepatitis B and C, which are bloodborne. It is fecal oral, which means virus is shed in stool. And so the people can shed virus in their stool 1 to 2 weeks before their symptom onset, and then when they're sick or just before they're sick, their stool has a very high concentration of virus, and then if they're not cleaning themselves properly after using the bathroom, then they can potentially have microscopic hepatitis A virus particles on their hands, contaminate food, contaminate other people, etc. It's acid resistant, so it can survive passage through the stomach. It gets into the intestines, up into the liver, excreted in bile, and excreted in feces. Clinical presentation, the big problem with hepatitis A is a very long incubation period, and so on average a month. So that's the time you get exposed to the virus from when you first develop your symptoms. And you're able to transmit the disease, the virus, up to 2 weeks before your symptom onset. So this is why it has spread. This is why we expect more cases will be reported to us in the coming weeks and even months. So a big challenge with us with respect to this particular virus. The symptoms can be wide-ranging. Some people are asymptomatic. In fact, a lot of children who would get hepatitis A virus infection don't often have symptoms, but they can spread it. Older people, people with chronic underlying conditions, other liver disease are more likely to get fulminant hepatitis A disease. Clinically evident abrupt fever, malaise, nausea, abdominal pain, vomiting, dark urine, and or jaundice. That's the obvious signs of any hepatitis, but certainly hepatitis A. Symptoms more likely in adults than children, and recovery can take several weeks, but death uncommon. So we have heard from the reports that we've been seeing that people have been sick for weeks, 2 to 3 weeks. All right, transmission, fecal excretion, primary source of virus in the stool 14 to 21 days before and 8 days after jaundice onset, longer shedding in infants and in children, person to person via fecal oral route, most common mode of transmission. Risk groups include international travelers, caregivers of adoptees, men who have sex with men or MSM, persons who use drugs, persons experiencing homelessness. All right, so now moving into the prevention and interruption of transmission, which is what I want to focus on. There is a vaccine for hepatitis A, and it is useful, it is highly protective, and so this is what we're recommending and promoting and trying to vaccinate as many people as we can who are at risk as soon as possible. So there are 2 inactivated vaccines available in the U.S. that were licensed in '96 for people 12 months of age and older. Both of the vaccines are highly immunogenic, meaning that they boost and mount a very robust immune response, even 1 dose. 1 dose is sufficient, though. It provides about 90 to 92% protection from hepatitis A, but a second dose will get a recipient up to 100%. So it is a 2-dose series, 6 months apart, but for the outbreak that we're in, 1 dose is fine. That is our response right now, is to get 1 dose into at-risk people. Okay, it is a routine vaccination as well and has been since 2006. So all children are recommended to get the vaccine, ages 12 to 23 months. And then catch-up vaccine is recommended as well if children didn't get it in those early years throughout their childhood. Children who travel internationally to places where hepatitis A is endemic, that are between 6 and 11 months of age, should get vaccinated as well. And then these other risk groups that I already talked about. The ACIP, or Advisory Committee on Immunization Practices, added homelessness as a risk factor in October of 2018 because of the national outbreaks that have been happening in other parts of our country. All individuals at increased risk for severe disease, so folks with chronic liver disease, other viral hepatitides like hepatitis B and C, are advised to get hepatitis A vaccine. And then also ACIP says that anyone interested in obtaining immunity should get vaccine as well. So those are the standard recommendations on who should get vaccinated right now. And these people potentially should have their vaccine covered by their insurance if they have insurance. All right, additional prevention strategies. So it's really kind of 2 things. One is vaccine. The second is hygiene, hand hygiene, after using the bathroom, after changing diapers, that kind of thing. Hand washing is preferred with soap and water over hand sanitizer, but either one is recommended. Safe sex practices, so this is spread through fecal oral, so people that do engage in oral sex, anal sex are at risk, so safer sex practices there. And then for people who use drugs, not sharing needles and works. All right, so that's kind of all the background I wanted to present on hepatitis A. And so with the next 10 minutes, what I want to do is describe all the work that we've been doing up to this point, and then to say that it isn't enough, it hasn't been enough, and now here we are. And to call upon the healthcare community to now boost and ramp up their ability to vaccinate at-risk groups for hepatitis A. I think the big challenge we've been having with this outbreak is we've known about this risk group and this problem for 2 years now, looking at it happening in other states in that border Pennsylvania, like Ohio and West Virginia. This population that's driving this outbreak in the country is very hard to reach because they typically don't present to healthcare, don't have a primary care provider, and don't follow up for health appointments. And when they interact with us, with government, sometimes they're just not willing to, they have other problems. So preventive vaccine for a problem they don't currently have is not high on their interest list for many of these folks. And so we've been out there in Kensington and other parts of the city offering vaccine to these people since last summer, but the uptake is slow. because we can't force them to do it, and we have to work with them to try to convince them that it's the right thing to do to prevent something, even though they have other social and health problems that are more pressing for them. The vaccine supply has been a bit of an issue as well. It's expensive, and we're doing our best to try to get our own supply, but we're really asking providers who can provide it and get reimbursed to ramp up their supplies now. And then raising awareness. We really see, even though this has been going on for quite a while, nationally and even locally, we've issued 7 health advisories and alerts since November of 2017. We often find that people in the clinical community in Philly really don't know that this is happening, or that there's an increase in hepatitis A and that it's a big issue. And so that was part of the reason why we declared a public health emergency and had our health commissioner, Dr. Farley, go on the news and describe why this is so important and what we hope to accomplish. And then implementing improved sanitation practices in at-risk communities. So this is work that's happening through the managing director's office to provide improved sanitation for defecation and hand washing and all of that in parts of the city where most people are homeless. But that hasn't happened yet, but the works for all of that are in place and should be happening shortly. Okay, so more specifically, PDPH is the Philadelphia Department of Public Health, that's us, and in the Division of Disease Control, these are all the activities that we've been doing. So the declaration happened on August 1st. For hepatitis A vaccinations that we ourselves have given, and we're not a primary healthcare provider, this is not the ambulatory health district health centers that the health department runs. This is disease control, nurses and doctors and other staff going out into the streets and other high-risk groups to provide direct access and provision of vaccine for free to people. And so 2,088 doses we've administered to date. The prisons has been an area where we've really had to have a presence because there have been numerous cases reported from the prisons, so that was 571. 636 doses we've just been doing on the street, and then 371 we've done in prevention point, where we've had a presence on a daily basis to the best that we can with a nurse offering it to people at the Needle Exchange Service Agency in Kensington. We've had to increase our hepatitis A surveillance, investigation, all of these cases that get reported to us. We have to investigate them to understand what their risk factors are, who else is in the household, who are close contacts, and then we've had to vaccinate those folks. So we have done numerous household-based close contact vaccination. We've been to restaurants because we've had some food handlers with Hep A, and we've had to vaccinate other restaurant workers. We had a grocery store worker down in South Philly in April who potentially could have exposed the community to hepatitis A, and so we did a press release, outed that Acme supermarket and informed the community to seek hepatitis A vaccine if they purchased food at that store. And then community education, we've been doing a lot to try to educate the public and other groups about hepatitis A and raise awareness, and then provider education. We've been in emergency departments numerous times and are providing lectures and other information in other healthcare settings to the extent that we can do that. And then we've issued 7 health advisories, 6 of them were health alerts on hepatitis A. And then we have our website, hip.phila.gov/health alerts, which is where all of them are logged, where they can be read. But also, if you don't know what I'm talking about with respect to getting the city's health alerts, you can go to this website and sign up to receive them directly over email or by fax. All right, we do track immunizations, so vaccines that are given in Philadelphia through our Philavax registry. And so this is a reporting system that providers need to use to tell us who they have vaccinated, which vaccine, and when the vaccines have occurred. This is the law in Philadelphia. All immunizations provided in the city are reportable to the city's health department through the Philavax registry. And so looking at adult hepatitis A vaccinations, now we don't know that these people are at high risk, but we know that they're adults and are likely in one of those categories of international travel, men who have sex with men, homeless, drug using, that kind of thing. So we're roughly seeing between 1,000 and 1,400 doses per month. That's kind of the baseline that our vaccinations we've done in disease control, but also the clinical community that report to us. It's a combination of all of that. So some vaccination is occurring on a monthly basis, and so that's good. However, it's not enough. And so what this graph shows, and I want to focus on this is what happened in San Diego, California back in 2017. And so Can they see my cursor, Brandon, if I do this? Okay, I'm wailing a cursor around this graph. So the turquoise bars are the number of cases reported in San Diego County, which is twice the size of us. They're 3.3 million, the whole county. We're 1.57. But in May of 2017, they shot up to 87 cases. This is our July. So we're right here now in this 73. This might be our August, the month that we're currently in. And you can see the green line coming across is the number of vaccinations that were occurring each month, less than 5,000. And it wasn't until they declared their public health emergency on September 1st where vaccination took off and soared, where they were able to administer 40,000 doses in the month of September. We spoke with the public health officials in San Diego, and they told us this is what quelled the outbreak. The rapid increase in immunizations that occurred following the declaration is what stopped the outbreak from occurring. And then you see that in October, November, December, the reported cases went dramatically down because the population became highly immune given through vaccination, and or also suffered disease and then were made immune that way. Okay, and so this table is also from San Diego, and it's the total number of immunizations that had to be administered to quell the outbreak, and it was roughly almost 200,000. And we estimate our population at half that, and so probably our target goal of immunization is around 100,000. But what's important on this chart is 70.8% were administered through the clinical setting, and 29.1% the county or the public health authority did themselves or worked with select partner agencies like jails to administer vaccine to high-risk groups. So this is why we're having this call, and this is why I'm asking and emphasizing that we really do need the clinical community to ramp up their hepatitis A administration practices so that we can boost these numbers as quick as we can. All right, so how can we work together? So the main points here are to vaccinate. Offer vaccine to patients most at risk for hepatitis A vaccine infection when they present. It's challenging with these drug-using and homeless people, but when they come to healthcare, say in an emergency department, potentially for an overdose or a laceration, that's the opportunity to vaccinate them for hepatitis A. And so we're asking that take advantage of that opportunity and give them hepatitis A vaccine before they're discharged. So again, the biggest populations we're focusing on right now with respect to the Philadelphia outbreak are people who use injection or non-injection drugs, people experiencing homelessness or unstable housing, people who are or were recently incarcerated. And then those are the top three, I'd say, right now. But then these other groups we certainly want to emphasize vaccine for as well, which are men who have sex with men, and then people with chronic liver disease like cirrhosis, other viral hepatitides like hepatitis B and C, and then HIV. And then we are hearing and we think that there are other groups that are at higher risk right now because there's so much more hepatitis A virus circulating in this homeless and drug-using community, particularly up in Kensington. And that would be healthcare workers who provide direct care to these people. And so any healthcare worker that is taking care of people who have these background risk factors should receive hepatitis A vaccine. And then community service providers. So people that work in shelters or provide medical assisted therapy or addiction treatment services or other homeless services, we feel that these folks also are at risk for hepatitis A exposure and therefore should be vaccinated. All right, so we also asked to recommend hepatitis A control and prevention measures for cases. So if in fact cases occur, offering vaccine to susceptible close contacts of cases, and so that would be household members, sexual contacts, and any folks that might share drugs or works with the case that you're aware of. Advise hepatitis A virus cases to take other steps to prevent transmission, such as hand washing, avoid food preparation for others, and then harm reduction practices around drug use while they're contagious, which again is 1 week after jaundice onset, or if no jaundice, 2 weeks after illness onset. And then to help raise awareness. And so we have materials, posters, brochures, other things about hepatitis A for Philadelphia that we want messages to get out there. And so we can certainly make that all available to you electronically, and we can print some materials too to some groups that aren't able to do that themselves. But to post those things in patient waiting areas, Other places like staff break rooms to raise awareness about what's happening, that would be great. And then counsel at-risk patients about prevention measures. And then keep reporting cases. We think the reporting is going well because we're hearing about all these new cases, but we definitely want to continue to hear about cases as they occur. All right, and then this is just a screenshot of some of the outreach materials we've gotten. We've developed these for targeted populations like homeless, people who use drugs, men who have sex with men, et cetera, and even some general informational flyers that are more appropriate maybe for a general audience. All right, and so where are the resources? And so our health information portal is our website, hip.phila.gov, and that's where you can go to navigate and find, these resources, the health alerts I spoke about, look at the recent surveillance trends that we're posting, and then also sign up for the Health Alert Network if you aren't already enrolled so that you can receive our health alerts directly when we issue them. And this is what the Health Information Portal page looks like. And so we have kind of a latest news sort of side to it. And then the menu on the left side is the way to navigate to things like health alerts or disease conditions specifically, and then other resources are down there at the bottom. Brandon Horvath, Kristen Feemster, myself, Steve Alice, we're here. If you have additional questions or want to have a offline conversation with us about your specific facility and how we can work with you to expand ability to provide vaccines, happy to do that. All right, any last questions for us? All right, everybody, thanks. Take care.